Hello, and welcome to Straight from the Hip, honest conversation about hip and groin. I'm Binoy, lower limb specialist from London, and joining me all the way from Perth, Australia, is my good friend Callum. Between us, we have assisted and treated and rehabbed thousands of hip, from weekend warriors to athletes, from stubborn groin pain to complex hip impingement and hip dysplasia. And here is the thing: hip and groin pathology doesn't fit neatly into your textbook boxes. It's messy, it's multifactorial, can be hard to diagnose, and frankly, it demands better from all of us as clinicians. That's exactly why we created this podcast. We're cutting through the noise and bringing you what actually matters in the clinic: evidence informed and always clinical relevant, whether you're a physio, osteo, sports therapist, or a strength coach. In each episodes, we'll tackle the presentation that walk through your door every single week. We'll going through some practical strategies, both in assessment as well as in treatment frameworks, and the confidence to manage these cases effectively, and when to escalate to higher further investigations and management. No fluff, no filler, just straight talking clinical guidance from two therapists who live and breathe hepatology every day. This is Straight from the Hip. Let's get started. And since it's the first episode, I'm going to briefly introduce myself. So I've been dealing with hips for the last 10, 15 years. I teach internationally, and this is something which I'm really passionate about. I work in the NHS at Guy's and St. Thomas's, and also work 2 days in the private side, which predominantly it's mainly second opinion. And this is something where I feel a lot of these patients go around not getting clear diagnosis and also being stuck. Having seen those cases, I find that's really important that we discuss those presentation, and that's what I'm really looking forward to linking up with Callum. Over to you, Callum.
Everyone, it's great to be here with good friend Binoy. So I've recently moved to Perth, Australia, so I'm not bragging at all to Binoy about how much better the climate is here compared to the UK.
And the coffee.
The coffee is a lot better, but I don't want to upset him too much or any of our UK followers. But no, I've been in the industry for about 11 years now. Background in strength and conditioning as well. So yeah, worked in the NHS and primary care, outpatients, private practice and sport in the UK. And not long moved to Perth, Western Australia, where I currently work in private practice as a senior sort of clinical lead physio. And yeah, quite often providing second opinion consultations on those complex hip cases. Do a bit of teaching as well, heavy on social media as well. And I suppose just trying to find my feet over here in Perth. And that's me in a nutshell at the moment.
So yeah. I think with anything, thanks, Callum. So anything, we all agree that most MSK experts say that the subjective is the key thing. So what we thought would be good is to get going. So what have we got for the listeners today, Callum?
Yeah, I mean, this is something I think, Binoy, you and I would agree that when we talk and we present, we say the subjective is your key. You know, a lot of the details are always going to sit in your subjective assessment, whether we're talking about hips or anything else. So FAI, we know, is a sort of an abnormal bony growth. So we can have a cam, or we can have a pincer, or we can have a mixed type morphology. So whether the bony spur, the bony growth is sat on the femoral head-neck junction, whether it's on the acetabulum, or whether it's a little bit of both. Generally speaking, this is going to happen in your active population. So I would say I typically see this be anyone between the ages of 16 and sort of 40 years old. It's quite a high male dominance. We do have to acknowledge that FAI does happen in women as well. But I think that we've got heavy evidence to suggest that hip dysplasia is much more common in women, symptomatically speaking, and FAI much more common in men or boys. Active population is key. So if you've got an active young male that comes into your clinic, if they've got quite a big sporting history, so if we say we had someone, a 24-year-old male that comes in, and let's just say he's got a heavy history of playing football from the age of, 7 or 8 years old, kept playing all the way through his 20s, that's going to give you a good index of suspicion that it could be FAI just based on that demographic entirely. I'd get asked a lot about family history. I don't know what you say to people here, Benoit, about this, but we do have some evidence to suggest there is a genetic link. So if you ask about mum or dads, and if they had hip issues, possibly hip surgery, whether that's a total hip arthroplasty, whether it's resurfacing or whatnot, and it happened from below the age of 50, it might increase your index of suspicion. but something that we do have to acknowledge as well. And I would say probably now in Australia, I get a lot of patients coming in with imaging that's already come into me. In your second opinion consultations, Benoit,
Of
I don't
course.
know if you get this,
Of
but
course. Yes.
a lot of patients come in and they've had an X-ray and it might show a cam or a pincer. But it's important always to acknowledge that some people can have these morphologies and not be symptomatic. I'd probably say I see that. Would I say almost just as often as I do see them symptomatically? Would you agree, Benoit?
Yeah,
In your
definitely. Yeah, so there's some great points you've got there, and I think you started right well on the demographics, which is generally an active sporting population. So it's very rare to see somebody who's inactive or overweight coming with that symptoms. So I think the childhood history. So there are a couple of points I usually ask. One of the key questions I ask is, tell me how sporty you were from the age of 8 to 18. We know that sort of importance of loading of the growth plates and how your body changes with the shape. So that really sets the scene. It's quite rare to see somebody with impingement if they've not done a lot of sports, especially rotational sports or impact sports. So that pretty much is a key thing. And maybe they're not doing it right now, but they've definitely done it sometime in the past, especially before the age of 20. So that's a key thing. And we know there's, I think that you must know this paper where they looked into hip heavy sports. So things like ice hockey, basketball, football, rugby, these are very strongly linked with that sort of morphology. So you really want to know whether they've done that. And an interesting point, as you said, is if you look at most of the literature, it's heavy on boys or men, where in the reality, I see like 70 to 80% of my patients I see in my sort of, both privates or NHS is women. So there seems to be a big gap in the research. So a lot of the research comes from sporting men, but the reality is we also see a lot of women. With the dysplastic, it's very clear it's mostly women, and a lot depends on the setting. If you're dealing with elite sports, you'll be seeing a lot more men, but with an MSK, it'll be very variable as well. So that's pretty much this. And the key point you said is the morphology doesn't mean symptoms. And good stats I use with my patient is if you 1 in 4 of us will on non-elite athletic population will have either a cam or a pincer or mixer type. And if you played a lot of sports, it is 3 and 4. So this is some stats which patients can relate quite quickly and say it's extremely common, but it's up to us as professionals to make that sort of diagnosis. So somebody walking in, especially in private sector like where you're doing, and here they'll walk with a report saying I've got cam and pincer or labral tears. So we'll have to, obviously we can't dismiss that. It's very important to acknowledge it, but then we have to see whether it matches. So yeah, so some great points on demographics and active profile and sporting. So how would you move on from that subjective sort of once you've sort of dig in on the initial elements?
Yeah, I think the other point I would pull up on there as well, Benoit, is that I will get sort of guys coming in and I will ask them, are you still playing sports? And they would say that they've always played football. I'll just use that as the example. They've played football from the age of 10, they're 30, that they've always played 2-3 days a week and that hasn't changed. So the other thing that I often ask is, what's been different recently? Because the one thing that we know is that if someone has picked up a cam at the age of 16, 17, and it could have sat there for 10 years, asymptomatic, and now it's become symptomatic at the age of 30. And you always have to ask yourself, well, why is that the case? And it might be that they say, well, I took 3 months off to go traveling and I didn't play football at all. And then I came back and I was playing 3 hours a week, which is what I was doing before I was going traveling. They may have come back at the same intensity as what they were doing 3 months ago, but because they've had
Mm.
3 months off to go traveling, that intensity, that volume, that frequency of training has now become alien to the hip. So maybe now that can spike off symptoms. And so I would say to people, if you get your patient saying to you, nothing's changed, try and dig a little bit deeper. Has there been a change in volume, in the frequency, intensity? Have they picked up a different sport? A runner that
Mm.
typically does road running here in Australia, they're now running on sand. Have you recently started making those
Seeing that.
adjustments? So that's something else I would go into the
Yeah.
subjective.
Yeah, definitely. I
Yeah.
think change in lifestyle, and sometimes it's not change in training, but I can give an example where a lot of people will connect is, with the COVID, a lot of people were getting onto Peloton bikes and indoor bike riding. So I saw a lot of spike in people with hip impingement where they had the morphology, but they were sitting much more than what they normally do. Or maybe they change jobs where they're driving with a lot. So I think sometimes it's that whole change in their loading pattern of the hip, whether it's sporting or not sporting, is hugely important. And it's very rare to see if they're not made any changes in the last 3 to 6 months for them to become symptomatic. So there's always an external trigger, but they may not know it. So it's up to us by digging by the history and going from there. So some great point there.
Yeah. Yeah. Did you fall into that camp, Benoit, in COVID?
Y-
Did you start jumping on the bike
yeah.
a
So I
bit
think the
more?
main thing that, yeah, the spinning was quite, obviously it was quite easy. Obviously, I didn't get the Peloton, but I thought a normal
Yeah.
spinning bike was good. But you can see how we can get into this pattern based on restriction. And the big one is like people changing jobs, whether one could be they're sitting too much or they're walking a lot, they're in a supervision role. Maybe they're doing 15 or 20,000 steps before they was not doing. And so we have to look at the total load. So that's quite crucial on setting up. So, and then how would you go into moving on to the symptoms and other elements? So once you sort of know their history, what would be your next
Yeah.
approach?
I think you've touched on it there, actually, kind of the aggravating factors. And one thing you pointed out there was deep sitting, deep squatting, if you like, or positions of deep hip flexion, we know is a key
Mm,
provoker for someone with symptomatic FAI. So I think the Peloton bike or whatnot is a very good example. I've had people jump onto the rowing machine. You're going backwards and forwards a lot, but they might just complain of simple day-to-day things, sitting in their car for a prolonged period, or if they're sat in an office desk and they're just sat for long periods of time. So that deep positions of sustained, prolonged hip flexion can be provocative. Internal rotation, which so that's an objective test that we can do.
mm,
But I'd say they're
mm.
probably the two movement patterns where they don't like deep flexion. And guys in particular, and a lot of this we know, Benoit, is down to acetabular femoral morphology as well, that we don't typically like the internal rotation position.
Of course.
So they
Yeah.
would be our provocative actions. You could get, we'll take the footballer again. If they're doing kind of a high speed run, or if they're doing a sudden change of direction, or if they're kicking with the intention to shoot, so there's a lot of power behind the kick as opposed to a regular pass, these are much more high loading related tasks that could be
Yeah.
provocative. Whereas they might find just a standard run, a standard passing of the ball is okay. The other one I've had is stairs.
Yes.
So we know with people with FAI, they're going to have much more anterior superior joint loading at their acetabular sourcil. So as they start to ambulate a hill or stairs, that impingement can be quite
Yeah.
profound, and the hip won't necessarily like those loads. So they'll try and find ways and strategies to compensate for that. So they're probably the top aggravating factors that I suppose I would see.
Yeah,
Do
definitely.
you have
And
anything to
again,
add?
like, yeah, definitely and also adding the gym going type where they will complain they're struggling with that sort of deep squats,
Yeah.
the deep lunges, the deep leg press. So again, they'll say like it's becoming like a nuisance where they can't do what they normally do. People are used to a particular sort of routine they have in the gym, and they find they have to make more and more modifications. So they have to adapt and becomes more stiffer. So one thing which I'm sure you must hear patients say this is that the perceived feeling of stiffness. So they've done a
Mm,
good training session, and then they feel like somebody has to stretch out, and then they go look online, see some top influences, and then they start pushing into internal rotation and gets into, because they feel like something is muscular, like it's deep, it's stuck, like hip flexors. So that's sort of asking them, how does your hip feel like after an intense training session? Does it take a day or two to sort of feel looser again? So that sort of gives you an idea. It's highly intraarticular as well. But definitely, I would entirely agree you. It's going to be the sitting, the deep squats, and with sports, it's going to be the cutting, turning, pivoting. And with running, I find it's mainly like uphill and sprint training
yeah.
is really
Yeah.
important as well. So, Callum, so when you talk about those are the ags, but what are they going to come to you? Obviously, we are in the pain business here, and people will come to you with specific pain here. So, what do you think is going to be the pain location and where they're going to present in?
Yeah, I think where you've mentioned, I think tight hip flexors, that's a bad word in the hip world, isn't it? It's a bad set of words. James Noak, if you're listening, we're on your
Yeah.
side, mate. I promise you. A sports medicine physician, doctor, guys, if anyone who hasn't followed James Noak, highly recommend that you do. But he would always say it's never the hip flexor. And when we're talking about intra-articular hip pain, completely agree. We're not saying you can't get hip flexor pathology, but people complaining of tight hip flexors, and it's more to reference what Benoit's just said, but also the fact that most of their pain is going to be a gradual onset around that anterior hip groin region, possibly even towards the pubic genital region. And sometimes it can refer down the anterior thigh. Rarely do I see cases where if it's not hip osteoarthritis, it goes to the buttock. I would say that most of the time it's around the anterior hip and groin region where they're getting their pain. I get people sort of talk about clicking feelings or like something might be
Yes.
catching or snapping. It depends on their description. And I think, Benoit, you and I sort of teach this type of thing about the signs that people give away. And I think the C
Yes.
sign is the classic one, isn't it? So if
Yes.
someone's sort of creating a crescent shape with their hands and they're sort of
Mhm.
grabbing around the anterolateral aspect of their hip, There are other signs. A deep pointer,
Yes.
exactly as it sounds, they're pointing with their finger deep into the hip, and they've also got a triangulation sign. So they'll kind of create a sort of this sort of triangle shape, like sort of this, and they'll press into their groin. So that's typically what they'll describe to me. Um, so they'll describe a lack of mobility. So I've had people say that they used to be able to do the 90-90 drill, which we don't want to upset any influencers, but especially on
Yeah.
our first episode. So we're not saying the
We want
90-90
them on our
drill.
side. Yeah. Yeah. Yeah.
We're not saying the
Yeah.
90-90 drill is bad, guys. We're not saying that. But for someone that's got intra-articular hip pain, because you're pushing the hip into flexion, internal rotation, they can find that it's painful, clicky, snappy. It feels very stiff in that groin region. I'd probably say they're my top ones. Yeah, not
Yeah.
to confuse things too much more.
What do we say, like a patient coming in? What would be their common, like, lines from what a clinician would like to hear from patients? Like, I'll start from one. I can't sit comfortably anymore. So, what else would he say? Patients would say,
Yeah.
sort of common lines.
Yeah, we've written some of these down. So I've had people say that I get a pinching feeling in my groin when I'm sitting or
Yes.
getting in and out of the car.
Yeah.
They might say when I'm tying my socks and shoes. So this is
Mm,
more a case of when they're sat down and they're flexing their hip to bring their foot up towards them, they get
mm,
that same pinching, horrible feeling.
mm,
They can't squat anymore. So when we're talking about gym goers that are really into their powerlifting or strongman lift, that type of thing, they start to say, I can't squat to 90 anymore. I can't get as low in my squats as I used to because of that pinching, horrible groin pain that I get. Those are some of the quotes that I suppose I've
yeah.
noted down that I hear.
Yeah. And what do you think is like, it'll be different from each clinician. So for me, it's a bit different. Is most people who come to like specialists like us, they're a bit fed up because things are not working. They don't have clarity. And what would you say would be the main sort of problems which make them to seek help? Do you think it's just the pain or lack of performance? What would you say when people start seeking physio or any other healthcare professional
Yeah,
with this
I think
patients?
I think it depends on the demographic, doesn't it? I think
Mm,
with me now, in my current position now, I'm dealing with a lot of active people. So
mm,
I would say the pain,
mm,
I would probably say the pain isn't the thing that brings them in actually here in
mm,
Perth, because
mm,
most of the active people I see, they will tolerate the pain for as long as is possible before it gets to a point where that pain is just getting on their nerves, it's irritating them. I would say the biggest factor that I'm seeing here is that it's impacting their ability to perform, whether that's cycling, whether it's running, whether it's in the gym. They're getting so frustrated that they can't go at the intensity. They can't run for as long or as quick, or they can't lift as heavy. Their
mm.
performance is what annoys them more than the pain.
Yes.
But when I
Yeah.
was working in AP clinics, primary care clinics, I would probably say it was the pain that was
Pain.
affecting
Yeah.
them because they can't do the simple day-to-day activities.
Yeah.
So I'd say it depends on the
Bit
demographic,
depend on
doesn't
that,
it?
yeah. Yeah. And what about
Yeah.
things like other things like, for example, like sometimes it's not straightforward, and many of them will have like a deep buttock pain, bit of night pain,
Mm.
lateral hip pain. How do you say with this sort of coexisting secondary patterns? You want to explore that?
Yeah, I mean,
Yeah.
screening, we
Mm,
know that if we're talking about lumbar spine screening, I mean, that's going to be very
mm,
important because that can
mm.
refer into the hip.
Yeah.
Your differential diagnostics, I suppose you want to make sure that you are dealing with intra-articular hip pain as the primary, not
Yes.
extra-articular hip pain. We
Yes.
know there are other differentials, Benoit, which I know we're not going massively into, but you want to make sure you're ruling out things like AVN, or when we're talking about runners, we want to make sure we're ruling out stress fractures, because that can present in a very similar way.
Yeah.
And that just comes down to your subjective screening, I would say,
Yeah.
more than anything.
Yeah.
Yeah, yeah, because I know that when you and I have spoken off camera, you
Yeah.
said you've come across a lot of femoral neck bone stress injuries, pubic bone stress injuries that's masqueraded
Yes,
as hip
definitely.
flexor tightness, FAI.
Yeah, we
Yeah.
can go into that. And obviously, I'll share from my point on this is the thing would be is what do you think people's perceptions are, what's happening? So one of the things I always ask is I ask them like, what do you think is happening? Which is always good because people go to Google or ChatGPT or all the sort of stuff, and you get a very varied response. So some people think it's highly muscular. They think it's like a tight muscle. They're overworking, or some people say the glutes are not firing, or they got
Mm.
pelvic tilt. So I don't want to dismiss that, but it's always good to. Very few people tell it's hip impingement, so they come with a different thing. Is this something you explore, and what do you think people normally say when you ask them what is happening? Patient
Yeah,
wise,
I would say that it's probably along the lines of that they think there's muscle imbalances. That's probably a big one that I hear, is that this muscle isn't as strong as this one. I've got an imbalance going on, or I'm just feeling very tight. So I've got to
Yes.
massage, I've got to dig, I've got to stretch. They're probably my top two. that I
Yeah.
would have people tell me. And,
Yeah.
tightness is a perception feeling, isn't it? I suppose if you've got an active person in the absence of any neurological disorder, we expect them to have high tone in their muscles, but that feeling of tightness is a perception to them. So we can definitely talk about the fact that this could be fatigue related. There's no doubt you may have some strength deficits right to left. I don't tend to say the word impingement. I
Yes.
think you alluded to that, Benoit.
Yeah.
It can
Yeah.
be maybe an
Yeah.
inflammatory nocibic
Yeah.
term.
Response. Yes.
So
So
I more tend
how do
to,
you cover that? How do you sort of approach that?
yeah. So I'd say to them, so here they often come in with X-rays already. So I'll say to them, yeah, look, there's a little bony growth here on your femur. And I say, look, we could have had that for a long time. And when we're doing these certain positions, there's probably a bit of, a sudden bit of contact that's happening between that bone on your femur and your pelvic bone. And your hip's just not liking that feeling. So we just
Yeah.
need to try and modify these positions. Let's adjust your training a little bit. Because if we can make the hip feel a bit more comfortable in these positions that are provocative, hopefully that secondary tightness or imbalances that you're feeling will start to feel a little bit more balanced, less tight.
Definitely.
So it's kind of not being
Yeah.
too medical around it
Yeah.
is my
Definitely.
approach.
Yeah, and I think the final point before we wrap up on that, we want to keep it relevant and also time sensitive because we want it to be more clinically, people are going to listen, rather than very long episodes. So one of the things, final point, which I want to highlight is the psychological impact. So I always, am asking them, how does it affect you mentally? Because the biggest concern I find is one, they can't play with the kids, or they feel like they're going to let down their mates in the football. So this is quite so how do you approach that element from the psychological impact
Yeah,
of the
it's
symptoms?
finding out what's important to them, acknowledging
Mm,
that. And if it's a
mm,
case of, we'll use the kids as an example. I feel like I can't play with my kids, and you acknowledge that and say, look, I totally understand that's a very important thing. You want to be able to play with your children. Make sure that they know that's achievable. Make sure
yes.
that they know that just because you have an impingement, it does not mean that you're not going to be able to play with your kids as you want to.
Yeah.
We need to we want to play with our kids, but we will probably just have to adjust how we're doing it at the moment. And
Yes.
if we work together, we build up some capacity, we build some tolerance, we improve our understanding of what's going on. There's no reason why you can't be playing with your kids as you want to. We're
Yes.
just going to have to allow a little bit of time. So it's massively acknowledging it, making sure they know it's achievable and that what they're feeling now is not forever. And that through collaborative work between you and them, it certainly is achievable.
Yeah.
So it becomes almost a bit like motivational interviewing, isn't it?
So definitely we want to give hope and positivity because they feel like sometimes this is never going to end, and that's
Mm.
obviously we can't promise any quick fixes or any I don't jump into the timelines, which maybe we can discuss in the future episodes. But they want to leave the first session sort of feeling that one, they've been acknowledged and heard, and also they feel like there's a plan. So what would you say from your point of view, if you feel it's a successful first session? Obviously we're not going to talk about objective, which we right now, but what would you say would be a good outcome for you from a patient perspective after seeing you on the first session?
I think the most important thing for me is that they've got clarity, understanding on what is definitely not going on versus what is most likely going on. Because I think we have to acknowledge, if we don't have imaging, I know, Benoit, you do ultrasound and that is part of your practice. It's not part of my practice at the moment. So we've always got to have an element of ambiguity and uncertainty. And I would say to any physiotherapist, osteo, chiro, whoever, that I think it's a mark of a very good practitioner if you can acknowledge that we can't be 100% certain, but this is likely a few things that are going on, and making sure that they've got clarity, full understanding on that. We don't need to give timeframes. And I do say that to them, look, let's just work week to week or bi-weekly to bi-weekly. Let's set a goal for the next week or the next 2 weeks, or 2 goals short term. And let's see if we can make those happen over the next couple of weeks so that we can grab those positives, acknowledge where you want to be.
Yes.
I explain to them that there's going to be up and downs, there's going to be peaks and there's going to be curves, there's going to be slips and downs in that journey, and that's okay. Giving that more to them as a sort of, this is what the rehab journey is going to look like. Base it more on their ability and their symptoms and their ability to adapt to what we're doing, less so kind of focusing on in 6 weeks, we want to be there. Because I
Yeah.
don't want them
So
to feel disappointed, like you're overreaching for something, and then they feel crushed that they haven't achieved what they've wanted to.
yeah, that's great. So I think that's the right place to bring this all together. So from a discussions, for me, these are some key takeaways I feel. So somebody walks in your clinic complaining of younger hip pain. So those are the key indicators. So first thing from the subjective is your demographics and activity profile. You're looking at young to middle-aged adults, typically from that 16 to 40-year-old, who are active, not just elite athletes, but recreational gym goers, weekend footballers, people who push the body regularly. If they fit this profile, hip impingement should be on your radar. So that's a key first point. And the second is the sporting pattern. So sports matter here massively, especially what they've done before the age of 20. So football, hockey, rugby, martial arts, ballet, heavy squatting, anything with repeated hip flexion, rotation, and load. And as you rightly pointed out, is pay attention to the training load. High volume during adolescence, growth spurts, intense sporting exposure. These are the key ingredients of CAM morphology development. And then when you look at the pain presentation, this can be quite vague. And this is where I think people get caught out, is not everybody has the C sign, but that makes our job easy, where they cup the hands around the front of the hips to show where it hurts. And also, is it like the deep pinching feeling or achy feeling? And you can also have buttock pain, lateral hip pain, and also into the thigh as well. So the location of pain is generally a bit diffuse, non-specific, and it can feel very muscular from a patient point of view. And point number 4, specific AGs. So we're dealing with hip flexion combined with rotation. Big one is prolonged sitting, especially in low seats or low cars, deep squatting, getting out of car, cutting and pivoting, tying shoes, as you mentioned. Sometimes it can be very vague, or limitation with cutting and pivoting with sports. So those are generally your sort of specific AG factors. And then it's generally a gradual onset with load-related flare up as well. It generally doesn't come from a single traumatic event. It's generally gradual, usually follows a training load spike in the last 3-6 months. It could be pre-season or change in training volume. And then a common thread people will say is the hip flexors are feeling tight, or they need to stretch or foam roll quite, or get dry needling, but it never settles. It might have some short-term effect as well. So there you have it. And finally, a key point which we shouldn't really be ignoring, especially when you think of this young active people, we feel like it might not have a big effect psychologically, but the evidence is opposite. In fact, they have more psychological distress than people with hip OA. So because it's affecting their identity, some people, their livelihood, and also future things like a family and also future sports as well. But those subjective red flags are really crucial. The right demographic, the right sporting background, anterior hip and groin pain, specific movement related AGs, and a load sensitive onset as well. So that sort of nicely wraps up. Any final tips before we wrap up this episode, Callum?
No, I love that, mate. You've summarized that very, very well. And we've done it in less than 30 minutes. That's not too bad, given we had our
So
little
I think,
introductions at the start.
Yeah. So I think for the first episode, I think, we'll move on from what patient tell us to what we can do. So I think in episode 2, Callum is going to dig more into the objective side, because the subjective sets the scene, but the objective is where you really confirm or refute your sort of diagnosis. So thank you guys for joining on the learning. And obviously, if you're want to know more about us, so we are all over on Instagram and also LinkedIn, and we, I've got courses coming up in London in March and April, so I'll put the links here. And any questions, please contact us on socials, and we'll be happy to listen. Thank you, guys. Thanks for listening, and signing off on episode 1 on Straight from the Hip.
Cheers, guys.